Good evening, all. Welcome to the 24th edition of TMC Medalogs. Today, we have another distinguished alumni of Tanjore Medical College, Dr. Thirunavukarasu. Most of you might have known him. And he is here today to talk about problems with the airways as far as children are concerned. Not all that wheeze is asthma. And it's important for us to know that not all that wheeze is asthma. Is going to expand on this. Dr. Thirunavukarasu is an accomplished otorhinolaryngologist with specialized expertise in pediatric airway surgery. Sir had done his MBBS, DLO, and DNB, and advanced fellowship training in pediatric airway surgery at Lausanne University Hospital, Switzerland. He currently serves as a senior consultant in the Department of Pediatrics at Kanchi Kamakoti Child's Trust Hospital and Apollo Children's Hospital, where he also leads the Center of Excellence for Pediatric Airway Surgery. So I would welcome Dr. Thirunavukarasu, sir, and I also thank you for accepting our invitation to address our alumni. The floor is yours, sir.
Thank you, Venkatesh. First of all, thanks for the invitation. And it's a pleasure for me and privileged to present for the alumni of Tanjore Medical College. I have fond memories of Tanjore Medical College, right from Fleming days and, in the other subjects and everything. And after that, almost like 30 years since I left Tanjore Medical College, whatever I have learned, I'm trying to, share my little experience, what I learned after that. My topic today is not all that wheeze is asthma. Why should I say that? First of all, it's not moving. Is it moving, Venkatesh?
No, sir. No, sir. It's not moving. It's not moving.
One second. So wheezing is an expiratory whistling sound produced by turbulent airflow passing through constricted airways. Right. This part we all know. But what about the other part? Though this term is often used in reference to asthma, wheezing or expiratory stridor can also be associated with other intrathoracic narrowing of the larger tracheobronchial airways. Not just intrathoracic airway, sometimes even the stridor, which is being produced above the intrathoracic part, can also be mistaken as wheeze, and it's been treated for many years. We're going to see such cases one by one hereafter. And probably at the end of the talk, you may also agree that why I'm saying that all that wheeze is not just asthma. Are you hearing the sound as well?
No, sir. Sound is not there.
Sound is not coming?
Yeah.
Once again, I'll just see.
Now sound is there. Yeah. Play பண்ணுங்க sir.
Yeah. Yeah. So what you're hearing is audible wheeze, right? So this child is referred from Madurai. This child was treated for wheeze, recurrent wheeze, for almost 2 years. After 2 years, the child came to me because at one point in time, the wheeze was not settling at all. So I did the endoscopy. what you're seeing there is in between the vocal cord, there is something which is stuck. I think you're able to see a yellow piece, small piece there in between vocal cords. So then I just removed that. What you're seeing is a piece of plastic, probably from a toy or something, which is stuck just in between the vocal cord. So there is a space in between the vocal cord. The child is able to breathe better. And whenever there is some insult, some inflammation, that time child have wheeze or something like that. Then they'll go to the nearby doctor. He'll give a nebulization. Child feel better, then go back. So this has been happening for almost 2 years. And, just a small piece got inside was treated as wheeze. So when you see, when there is obstruction at this level, then you will get inspiratory stride. When there is obstruction at this level, you will get expiratory stridor. When there is obstruction at this level, then you will have biphasic stridor. But, this area above whatever is there, there is some obstruction here, like adenoid or tonsil or something like that, then there will be something like snoring that is very easier for us to pick up. So I'm not going to talk anything about that now. So the airway, though it starts from the nasal cavity till the bronchus, we are going to concentrate from here to here because these are all the areas where the wheeze is mistaken as stridor, or stridor is mistaken as wheeze. So how do we evaluate these children? So generally, the evaluation happens only by endoscopy. So the endoscopy is gold standard. We don't rely on other investigations, mainly imaging, maybe for some extra luminal obstruction, we do imaging. Otherwise, for intraluminal pathology, the airway endoscopy is gold standard. Though there are different types of endoscopies we've been doing, I generally call it airway endoscopy because it is not, specific to say that transnasal flexible laryngoscopy or bronchoscopy, direct laryngoscopy, telescopic bronchoscopy, suspension microlaryngoscopy, ventilating bronchoscopy. There are many different types of scopies, but overall we call it airway endoscopy. So this is a normal child. A flexible endoscopy is being done. So the child is lying down. We're past the scope from the nasal cavity. We're going further down. I want you to watch carefully all the structures because I'm going to explain in stage by stage in every single station how the pathology can cause wheeze or audible stridor. So here you are seeing adenoid pad, the nasopharynx, and if you're going further down, you will see the soft palate, which is approximating. And then if you pass the scope further down, what you're seeing there is epiglottis and posterior one-third of tongue, valvula, and then aryepiglottic folds and arytenoids, and then false vocal cord and vocal cord. If you go further down, subglottis and the trachea, we can go down, can see is there any pathology in the trachea, especially tracheoesophageal fistula opening in the posterior wall. That is carina. And I'm going into the left main bronchus and further down to the bronchial orifices. And I'm coming back, I'm going to the right main bronchus and upper bronchus opening, and then middle and lower bronchus. So there can be problem at any stage when there is some pathology in this airway. So this child, there is some inspiratory stridor. If you watch carefully, the voice is something like hot potato voice. That means there is something there. So something like a fish mouth in the laryngeal inlet, what you're seeing is laryngomalacia. It's easier for anybody to see the curling of epiglottis. That is a laryngomalacia. But if you watch carefully, if you go up a little bit, there is a cyst sitting in the posterior one third of tongue, which is pushing the epiglottis further down. So that means there is a ductal cyst sitting in the posterior one third of tongue, which is occupying both valvula and pushing the epiglottis. So I'm using a radiofrequency ablation for precisely cutting the cyst all around. Once this is cut, you can catch hold of the cyst and pull it down and carefully remove a little bit of tissue as well, so that there won't be any recurrence at all. So after surgery, you can see the child, that is post-operative period, after 1 month, how peacefully the child is sleeping. So once this is done, then you can keep the child intubated for some time. If you want, you can also pull the epiglottis up and then suture it, or otherwise you can just leave it like that. And also you can release the aryepiglottic fold, and the child will be all right after some cicatrization of the aryepiglottic fold, so that the collapse won't happen later on, something like a laryngomalacia that is typical problem of supraglottis. So that means you intentionally rigidify the supraglottic part, and then child will have a normal supraglottis after maybe 3 weeks or so. So this is a proper laryngomalacia. You can see the inspiratory stridor. So see, the supraglottis is being sucked in whenever the child is inspiring. The whole supraglottis is being sucked in, and the arytenoids, aryepiglottic fold, epiglottis is completely covering something like a lid over the supraglottis. So we did supraglottoplasty for the child, and this is after 1 month. You can see how nicely the epiglottis is rigidified on the left side, and the right side, the child doesn't have any stridor at all. Watch this. The child is having high-pitched stridor, especially during sleep, and during endoscopy, you can see both the vocal cords are mobile. There is good adduction, but there is no abduction at all. So that means this is bilateral vocal cord palsy. Very young babies, the bilateral vocal cord palsy may be because of some problem in the nerve, maybe in the intracranial pathology, especially ulnar cavity malformation. But the middle-aged or adolescent girls will have something like an idiopathic bilateral vocal cord palsy, like in this case. So I did a posterior cordotomy. I'm using a radio frequency ablator again, so that I'm cutting the left vocal cord posteriorly, and also I'm cutting the left false vocal cord above. The idea is to give the space for the child to breathe, so the posterior aspect will have some space for the child to breathe. Here I'm also removing a small piece of partial arytenoid cartilage, and now I'm using a coblator to ablate the extra tissue there in the lateral wall, and I'm going up to the perichondrium of thyroid cartilage, so that now we can see the wide opening created in the posterior aspect of the glottis, so that the child will have a better space for breathing. So now you can see the posterior glottic opening after 3 weeks, the healing will be proper and there will be good mucosalization. You won't see that kind of a raw area what you have created. And luckily, there may not be much problem in the voice as well.
ஹாய் சார், இப்போ எனக்கு தொண்டெல்லாம் எதுவும் வலிக்கலாம் இல்லை. பட் ஆனால் நேற்று டியூப் இட்டும் போது லைட்டாக வலிச்சிச்சு சார். ஆனால் இப்போ வலிக்கலாம் இல்லை, இப்போ ஓகே தான். பேச்சு முன்னோட இப்போ கொஞ்சம் வந்திருக்கு.
So you have normal voice and the breathing has become normal. So sometimes you will have something like this. This is ALTB, acute laryngotracheobronchitis. The patient may present with a croup kind of cough. When you see inside the endoscope, you can see the inflammation right from the supraglottis in the lingual surface of epiglottis. And then if you go down, you can see the inflammation at the false card level, and the vocal cord is inflamed. That means you will have a hoarse voice. So that is a clinching point for this kind of children. We have acute episode and breathing difficulty as well as voice abnormality, and there will be inflammation everywhere in the trachea up to the bronchi. So here you need to just conservatively treat the child, be all right. But sometimes child can present to you with recurrent croup. Child. So we need to rule out, is there any aspiration happening? Because of that, the recurrent croup is there. So what we do is a functional endoscopic evaluation of swallowing. We pass the flexible endoscope through the nose and feed the child, see what is happening there in the supraglottic level, whether the child is able to swallow, whether the liquid, whatever is swallowing, is going into the piriform fossa and through the tracheopharynx and the esophagus, or is there some penetration or aspiration into the tracheobronchial tree? So in this case, there is no aspiration. So that means the recurrent croup without any aspiration. So in this situation, what we do nowadays is do a laser pepper spotting. That means you create raw area, leaving island of mucosa in between here and there. So you are technically rigidifying the subglottic loose mucosa so that the whole area will be rigidified, and there won't be enough chance for further loose area for the inflammation to happen later on. So this is the laser pepper spotting, and this is after 3 weeks of video. You can see the subglottis is nicely mucosalized and not much of loose area. This is the first POD of the child. So this child, a 2-year-old child,
Talking, ma.
check the voice.
Talking.
So the child had abnormal voice since birth, and stridor now and then, and wheeze. And when I did endoscopy, I could see the congenital glottic web, which is extending down into the subglottis. I'm not able to pass my scope, so I did tracheostomy, and through that there is a retrograde scopy on the right side. What you are seeing is the free border of the web and subglottic stenosis. So I did a laryngotracheal reconstruction with the costal cartilage graft, and the web is nicely released. And the voice is also become almost normal. Here, the subglottis is expanded with the costal cartilage grafting. You can see nice mucosalization, and the child was decannulated and became normal. And this baby was 4 days old baby, came to me a couple of weeks back, and the child had stridor. There is a history of intubation. You can see there is a biphasic stridor and the voice is not there at all. And I did a scopy. There is a glottic wear, and the child was intubated. The person who was intubating didn't notice that voice was abnormal, so he tried to intubate, and because of the narrow glottis and subglottis, there is intubation-related injury and mucin deposits. What you're seeing there is a mucinous deposit in the subglottis, and straight away I used the cold steel forceps to remove that, and then I used the balloon to just balloon that area. Before that, I just released that web by using a sickle knife just to cut in the midline so that the web is released. And then I'm using a airway balloon. That is some amount of neosporin H ointment and dilated. What you are seeing is the dilated part. Now I'm passing the nasotracheal tube to intubate, and I caught hold of the tip of the endotracheal tube, passing it through the glottis, and once that is gone in, you can leave the child intubated for 48 hours and then extubate. So you can also apply some more neosporin H ointment so that the healing will happen around the tube. And once the child is all right, you can extubate after 48 hours. So this is few weeks after. There is a little bit of sound, residual sound, but otherwise the child looks okay. So this child was referred for stridor. The child had undergone surgery for hiatus hernia. You can see the sound, that is a biphasic stridor. And when I did endoscopy, I could see there is a subglottic stenosis, that is post-intubation subglottic stenosis. Then I used sickle knife just to release that band, and then use the airway balloon to dilate that subglottic area. You can keep it dilated for maybe 2 minutes if there is no saturation coming down to 70 or so, and then remove the balloon, and you can see how nicely it is dilated. And this is the postoperative period. The third POD, the stridor vanished. The child is breathing peacefully. So this poor boy was referred to me with treatment of wheeze for almost 12 years. He had a history of intubation when he was 2-year-old for some other reason. For I think it is for dengue fever, and then extubated. He's been having stridor now and then, especially exertional stridor, and he was treated as asthma for almost 12 years. You can see the biphasic stridor. Sometimes you can hear the noise with the naked ear, or you can auscultate. You will be able to pick up the biphasic wheeze. And I did a scopy. You can see the vocal cords are fine, and there is a subglottic stenosis. Again, a thin stenosis. And there is a band which is from the right vocal cord to the posterior glottic region. I inject a little bit of Kenacort, that is triamcinolone. So all around we can inject so that the scar formation will be reduced. And then I'm using a sickle knife to make a cut. This is called Mercedes-Benz cut, something like a Mercedes-Benz signal. You cut on 3 areas, and then you can laserize that posterior part a little bit, but you can't completely go up to the level of cartilage. That will give a perichondritis. Then use a balloon to dilate. And as I said, you can keep it for 2 minutes and remove that. You can see the subglottis is nicely wide open. There is a small shelf. That is not a problem as long as there is no problem for his breath. So this is the postoperative. There is no stridor. He has a peaceful sleep. So this child undergone a surgery for TF, and after that developed severe stridor, and that is post-intubation injury, acute injury. So I managed it with the conservative ointment application for and kept intubated for 48 hours and then extubated. And this is the post-operative after 3 weeks. So the child is happily playing with this toy. So how do we manage this kind of, endotracheal tube intubation? And then, this is not a very rare situation like this. There is some mucosal laceration. And in this situation, if you allow it to heal on its own, there will be a perichondritis and scarring. And unfortunately, in the airway, you don't need just the healing, but the healing in the appropriate area so that the lumen will be preserved for the patient to breathe in and out. So what we do is we re-intubate with one size smaller tube and apply neosporin H ointment all around so that the healing will happen all around. And you need to allow the healing to happen in an appropriate manner. So I suggest to all of you, whoever is intubating a child for whatever reason, when there is a chance of second intubation or third intubation, you always smear the endotracheal tube with neosporin H ointment and re-intubate so that the healing will happen all around. Otherwise, if there is mucosal laceration, that will heal by scar, and unfortunately, that will create some problem for the lumen. So this child was referred to me when the child was 6-year-old, and he has been having stridor almost since birth, now and then, and he's been treated as recurrent asthma. And at one point in time, he was treated as unresponsible asthma for medication, and he was referred to me. And the child is almost like having severe stridor and the muscle wasting and everything. And I did a scopy. For my surprise, there was a congenital subglottic stenosis, and he's been treated as wheeze for almost 6 years. Then, luckily, there was no tracheostomy, so we started intubation. But the intubation is difficult, so we started with the LMA, and then I opened the neck, did a temporary tracheostomy just for the surgery, and intubated through that, and circuit is connected to that fluxometallic tube, and the anesthetist started ventilating through that, and I opened the anterior cricoid cartilage and harvested a costal cartilage graft, rib graft, and then nasotracheal tube is passed down, and I placed the rib graft over that anterior split and sutured it and applied a little bit of tissue glue around and then sutured it. This is after 6 months. Now you can see the subglottis. You can see the graft is nicely healed. There is a good mucosalization, and now I'm able to see the lower trachea up to the carina. So this child can see the biphasic stridor. The wheeze is biphasic and the cry is abnormal. And I think to just jump it up. Another case, same biphasic stridor, but the child is not able to produce any voice at all because there is no good air burst happening in the subglottic region. And this is the previous child with biphasic stridor. Voice is not all that bad. That means there is some space below and there is a cyst sitting in the trachea, almost in the mid-trachea. And I excised that cyst endoscopically, used a long telescope and a laryngeal wand coablator to ablate that cyst, and leaving behind the superior surface of the cyst as an anterior tracheal wall. And I left the trachea undisturbed without intubation, and in immediate postoperative day was little stormy because of the stridor and inflammation around that cyst, but after that child became all right. So now what you're seeing in the anterior tracheal wall, because of the cyst, the tracheal wall is being pulled down, and once everything is cleared, you can see the anterior tracheal wall is stiffened, and this is the postoperative period.
Distress?
Distress is not
Huh?
there. Distress is not there. That
Noisy baby not there.
like secretion sometimes.
Now the voice is also become almost near normal, and the breathing has become all right. The other child had a post-intubation tracheal stenosis. That means the lower end of the endotracheal tube is caused this injury, and because of that, almost there is a pinhole opening in the trachea. And then I laserized that area and ballooned it. This is the postoperative scopy. You can see the lower trachea. It's almost normal now. You can see the carina and both the bronchus opening without any problem. And this is the postoperative period. Now the voice has become completely normal and breathing is better. So this child was referred from Calcutta, a 4-month-old baby with severe biphasic stridor, and the child had long segment congenital tracheal stenosis and LPA sling. So with the help of cardiothoracic surgeon, we opened the chest and they did the LPA repair, and then I did a slide tracheoplasty. That means you cut the trachea in the midline and slide it over so that you won't have to resect any part of the trachea because this is the long segment congenital tracheal stenosis. You can't resect the whole length of the trachea. So you can slide it, and then what you're seeing is the postoperative whole trachea. I'm able to pass the scope all along up to the carina. And this is the postoperative. So this child came without any history of sudden breathing difficulty, and there was a pink frothy secretion. That means the child is in pulmonary edema. So that means there is some obstruction in the central trachea. So did the scopy, and then there was a foreign body in the mid trachea, and we removed the foreign body, and the child became all right immediately. So this child was referred from Kanyakumari, and child was having unresponsive wheeze for almost 6 months, and then they sent the child, and the first X-ray you see there is some hyperinflation, probably a foreign body, but it looks like the other side also some kind of hyperinflation. So we were puzzled. Then we did a scopy. So we are able to remove something from both the bronchus. So that is the Christmas tree. The child has swallowed this, and it went to both the bronchus and stuck there. And because of that, it looked like exactly wheeze and bilateral wheeze. And when we removed this, and then child became all right. This child came with the severe stridor, almost like a island chest at one point in time. The saturation is only 56% at that time, and the X-ray looks bizarre. We did a scopy, and there was something like a thick pus. Then we aspirated. It couldn't be removed by aspirator, and then I used a foreign body forceps to remove that, and it came out like a bronchial tree. So this is a bronchial cast. So that is like slowly building up on both the bronchus, and it looked like a unresponsive wheeze, and the child was all right after removal of the cast. Sometimes there may be foreign body of both the bronchus. Peanut has gone inside, broke into two pieces, one piece into the right main bronchus and another piece into the left main bronchus. So that means the child presented with a bilateral wheeze, exactly like bronchial asthma. Then we removed the foreign body using a telescopic foreign body forceps. And it's always nice to use a telescope so that you can see the other side. There is something you can remove the remaining foreign body. Sometimes there may be multiple pieces of peanuts lodging there, and you can always have a second look and remove all the foreign bodies. And also, when you're doing it, your anesthetist is looking at what is happening there, and giving anesthesia is become easier, and your assistant also watching what's happening, and it is easier for them to also assist you. So how early can we intervene in these kind of airway problems? So this child, we intervened at birth. the child was diagnosed have a huge goiter in a fetal scan, and then we decided to do a exit procedure, that is ex utero intrapartum treatment. That means there will be a two team of surgeons, one gynecologist, and they will be doing a cesarean section in the upper part, and the lower end, the otolaryngology team will be there, so that once the child is just delivered, the head is just out and shoulder is in, and still the child is getting blood supply from the placenta, and we try to intubate the child, and if not possible, you can use a telescopic forceps to visualize inside and intubate it with the help of telescope, and then we move the child out of the area, and we gave therapeutic thyroxine for a week, and after that we extubated the child. The child became all right. So now I think you all agree that not all that wheeze is asthma. That's all from my side. Thank you very much for the patient audience, and I'm happy to answer your questions.
Thank you, sir. That was a beautiful lecture. I mean, the videos were excellent quality, and you began with actually demonstrating the anatomy as we go down, and it was much easier for us to follow it with the later slides, later videos as well. I mean, it's imperative that I mean, I'm very scared of pediatrics, and to work in a small area in pediatrics, especially the airways, is such a very important area. It was very fascinating. Thank you for the great presentation. Now the floor is open for the audience for further questions or comments.
Sir,
Hi, Vengam, Murugesh.
Chalunga sir, go ahead, sir.
Thirunavukarasu sir, it was very nice presentation. I am Murugesh from. You remember me?
Hey, Murugesh. Yeah, of course,
Sir,
of course, Murugesh.
Yeah, it's fantastic, sir. All the cases, it's very revealing and very nice, and the picturization and the description, everything was excellent. And sir, infection point of view, if you have active viral infection, you do get that, isn't it? Do you treat and then intervene, or do you actively manage when someone is having active infection? That's my query, sir.
I mean, it depends. It depends upon the pathology. If the child is having something like ALTB, then we don't intervene at that particular time, right? The viral infection, acute laryngotracheal bronchitis, we don't treat, we don't intervene those children. So we treat the child, and if there is recurrent croup, then in between two episodes of croup, when the child is normal without any infection, then we intervene. So when there is active infection, we don't do that. Unless otherwise there is something like abscess or something, then we need to drain it, we'll do it. Otherwise, we don't generally do it.
Thank you, sir.
Yeah, there is a question
fantastic listening to you.
Yeah, there's a question in the chat box, sir. Dr. Rajendran wants something about non-tracheomalacia, a few words about it.
Yeah, I mean, tracheomalacia is a very, very tough, condition to treat. But nowadays, the tracheomalacia is also being treated, because generally, the tracheomalacia or laryngomalacia, most of the children will outgrow it. If you allow the child to grow a little older, they will outgrow it. But some children, maybe 10 to 20% of the children, cannot withstand that kind of severe insult, and they won't put on weight, and the failure to thrive, all those things. Then we need to intervene. So there are many different kind of treatment is being done nowadays. Endoluminal stents. But majority of those stents are not helping the child in long-term basis, because there will be some problem in the mucociliary mucociliary mechanism, because of the stent will impede the mucociliary process. And then you can also do external PEXIS. We have started doing some of the kids, very severe kids who are on BiPAP at home. So nowadays we are doing external PEXIS, like anterior and posterior PEXIS. One of the leading tracheal surgeon from Great Ormond Street, London, is coming to our hospital once in 6 months or so. We have a tie-up with Great Ormond Street, London. He comes and helps us for fixing up those anterior and posterior wall of the trachea with PEXIS. But having said that, it's a very long surgery, very cumbersome, and the child has to withstand all those post-operative period, because already the child will be struggling to live without any thing. And these surgeries are not very well validated yet. That means there are multiple procedures, no single procedure to do tracheomalacia fixation. That means we are not at there. So probably in future we'll be able to manage those kids better.
Dr. Nandakumar, you raised your hand. You want to ask your question?
That's right. Yeah. Thank you, Venki. Hello, sir. I think our pathway class to one of your juniors, during the time during our medical school days. That was an excellent presentation. Thank you for educating us. My question to you is, at what point in time you decide to do a bronchoscopy? It's very common for kids to see coming with bronchiolitis and all that, pediatrician treating them. Sometimes it's very hard to differentiate a stridor from wheezing. So, what point in time, you think, the bronchoscopy?
Nanda, your voice is kind of.
Your voice is not very clear. It's breaking.
Can you hear me now?
It's slightly better.
Better.
Okay. So my question is, at what point in time, do you decide to do a bronchoscopy on kids? Because
what point of time we decide to do bronchoscopy for any child who has got stridor, right?
Yeah, sometimes it's and sometimes one of the cases you mentioned is it's not obviously sounds like a stridor, but it looks like a wheeze, the kid with a foreign body in the upper airway.
Those children are treated as wheeze. Once the wheeze is not responsive to medical management, so then the patient is being referred. And that point in time, we decided to do scopy. And some of the time, some of the cases, these kids will have problems. And nowadays it is easier for every kid to get the nebulization done. Any problem, they'll go to ER, and every single child with wheeze or stridor is being put on nebulization. The child will feel better a little bit, then they think it is responding well, and the child will go back and come back with the problem again and again. At one point in time, there will be a static wheeze for a longer period, which is not responding to any kind of medical management. Then obviously we have to scope the child and see what is happening inside. And another thing is, we need to look for other symptoms like voice abnormality or swallowing problems. Most of the time the voice is neglected, and when the child is having stridor or wheeze, then we think it is only the lower airway. And when there is abnormal voice, that gives you a clue that there is something else happening. So that time we scope the child. Or if the child is having some swallowing issues and recurrent aspirations, that kind of symptoms, then again that is the indication for scoping. It's not just the wheeze, or sometimes the child is having a first episode of wheeze, and which is not responding. Or if there is a clear history of foreign body aspiration, and the child is very young and having wheeze under 5 years. So these are all the multiple criteria you can have to do scopy, and there will be many surprises when you do scopy, because we are in the process of publishing a paper for the past 10 years of our yield of endoscopy, airway endoscopy. what are all the yield, what are the cases we have done scopy, and what is the yield, and how many patients we have picked up with pathologists. So that's going to be published. Thank you. Thanks for the question.
Oh, that makes sense. I appreciate it. Thank you.
Dr. Sony, somebody has risen his hand. I don't see his name. Please go ahead with your question, sir. Okay. Sir, go ahead, sir. Please, sir. Good evening.
Dr. Thirunavukarasu, wonderful presentation. Very
Thank you.
wonderful presentation.
Thank you.
If you don't mind, what I was taught, we should be able to differentiate a wheeze from croup and stridor clinically.
Yeah, I mean, yeah, most of the time, clinically we'll be able to.
When there is a stridor, the patient should come to you. Whether you heard about him or the Kejriwal had something about this. You heard about him?
Sorry, sir?
The Kejriwal, CM of Delhi.
Kejriwal, yeah.
Yeah, that fellow was always coughing. You must have seen him before. He had something, whatever, I do not know the ENT term, what they used. They did it in Manipal Hospital, Bangalore.
Okay.
Now he's not coughing.
Okay.
Something, Eula, something, I don't remember exactly. It's some few years back.
Okay, I've not heard about that, sir.
Just. Anyway, wonderful. It's a lesson. Very thrilling.
Thank you, sir.
To see this, your scopy.
Yes. So sorry, sir, I didn't get your name.
I am Captain Dorai Rajan.
Sir, sir, you are my teacher. You are my teacher, sir. Thank you so much. Thank you so much, sir, for being here.
But now I learn from my students.
We've learned a lot from you, sir. All your blessings.
Thank you. God bless you.
Thank you, sir. Thank you so much.
Sir, can I speak?
Yes, sir. Go ahead, sir.
Yeah, I put a question in the chat box. You keep using Neosporin H ointment. That's what you were. Have you ever injected mitomycin C?
Yeah, I mean, we used to inject mitomycin C for some of the patients. It's not injection, topical application of mitomycin C, but unfortunately, we don't know when the mitomycin C works. For some, it works. For some, it won't work. So my Professor Philip Monier, my mentor, he used to say that mitomycin works on Monday, Wednesday, and Friday. So that means nobody knows, when it works and when it's not going to work. That is one thing. And second thing is there is always a fear of carcinogenic reaction by mitomycin C. So one can use the mitomycin C for only twice for lifetime. So that is the biggest limitation for that. And you don't have clear-cut data to say that it works all the time. And there is a limitation in it. So in that situation, if something else which is having a less complication and works well, then why not? So that's why we started using a topical application of Neosporin H. In Western countries, they get diprogenta, that is gentamicin and dexamethasone. Here, we have Neosporin H ointment available that we use only when there is mucosal breach in the post-intubation stridor patients, and we apply local applications. In case if there is a well-formed scar, then we use Kenacort, that is triamcinolone injections, like what I showed in one of my cases.
Yeah. So the reason why I asked is sometimes Neosporin causes idiosyncratic huge edema when used on the skin. Hello?
So, yeah, I mean.
So that will be disastrous in the airway. Hence my question.
Yeah, I mean, we have used Neosporin H ointment only when the patient is intubated with one size smaller tube, and all around we apply neosporin H. The child will be intubated for 48 to 72 hours, and then we extubate. So that means, the contact area will be all around. And even if there is some edema, that will not cause any problem because already the child is intubated. And after for 72 hours, we extubate. We never had that problem what you described. We have done almost like 70, 80 patients so far. There is no single patient had any problem after usage of neosporin H.
Thank you very much.
Thank you, sir.
Yes.
So Dr. Gokula Krishnan wants to know how long to wait for response to wheeze. In one of the case, bilateral foreign body looks like wheeze. So he wants to know how long one should wait before we actually think of airway disorder other than wheezing.
Yeah, I mean, the child is having a bilateral wheeze. Anybody would treat it as wheeze. It is that there is nobody can mistake about it. But if the child is not responding to medical management, you can't allow the child to struggle for 6 months, like what happened in this particular case. The child had retrospectively, when we go back to the history, and they said there was Christmas happening at home, and the Christmas tree was planted at their house, and that time the child is like 1.5-year-old kid. Somehow it has put the leaves of Christmas tree inside, and nobody knew about it. But the child is deteriorating day by day, going debilitating the situation. At one point in time, it is very, very, very sick child. When the child was brought to us, it's almost like dying, and you can't allow the child to go that far just for wheeze, right? So if the child is not responding, then that means there is something abnormal happening. You need to scope it. The scoping is not a big deal. You can just do a flexible bronchoscopy. It is available everywhere now. You can just scope the child and see what is happening inside if you have any doubt at all.
So there's one more question.
How often you employ? Hello?
Yeah,
please
How
go.
often do you apply CT scan before scopy?
Yeah.
I mean, I'm not a big fan of CT scan for anything at all. We generally don't do CT scan that much. And, if at all, if I need, I rely on X-ray, plain X-rays. That will give you, very good clue about it. In case you are not able to pick up anything in the X-ray, and there is a history, or in case if you think there is some complication because of that. Sorry?
No, sir. Go ahead. There's some disturbance. Yeah.
Then maybe yes, but generally we don't go for CT scan, but that is more of parenchymal problems. So you will have to do CT, not for picking up anything in the airway.
So there's another question. In torticollis, a patient with torticollis presents with severe respiratory problems. Have you had any prior experience in this kind of situation?
Many situations. The child, even I have a child.
Yeah. Go ahead, sir.
Yeah, even I have a child right now in the hospital. Day before yesterday, I drained a retropharyngeal abscess. The children will present with torticollis. It's just right away they'll go to the orthopedic surgeon first, and they'll see the torticollis, and maybe they'll take X-ray, and they will find out there is widening of prevertebral shadow, and then they'll refer the patient to us. Sometimes the patient will have severe odynophagia or dyspnea or severe breathing difficulty. They'll come to us, and once we examine the child, most of the time we'll be able to pick up a bulging in the posterior pharyngeal wall. Then we will take up the child for abscess drainage under general anesthesia. Sometimes, if need, we will also go for imaging like MRI to see where exactly is the abscess, whether it is involving the danger space in the retropharyngeal part, or if it is in the prevertebral area. In case of tuberculosis spine, you will have cold abscess, then there may be a prevertebral space involvement, then the imaging will be very useful.
Yeah, can I just ask a question, Dr.
Yeah,
Thiru?
Yeah, please.
Go ahead.
Yeah, Dr. Thiru, this is Rajan Maheshwari from UK.
Hey, Rajan. Good to hear from you, man.
I have been listening to your talk. It's been really good. I mean, most of it is obviously ENT related, so that's a bit of a bouncer for me. But I'm an pediatric orthopedic surgeon, as you know very well. I see a lot of babies with torticollis at all ages, 3 months, 6 months, and even older than that. Very rarely I see a respiratory problem in association with torticollis, but whenever there is one, I feel that at least in our unit, there is a bit of a reluctance to do any intervention. I believe most of these, and you will correct me, do correct with time, physiotherapy, and when the torticollis gets better. But how often? I know you said you do see a few patients with respiratory problems with torticollis, but is that rare or you see them commonly?
I mean, exactly. It's a very rare. I mean, there are multiple reasons for torticollis. We're not talking about the general torticollis. Torticollis with some abscess. Okay, so sudden onset of retropharyngeal abscess or prevertebral space abscess or danger space abscess with the torticollis, then we intervene. But you will see more number of torticollis patients other than the infected causes. Now, those patients you will treat with physiotherapy or whatever management. In case if there are torticollis with some amount of prevertebral shadow widening in X-ray, then they'll send the patient to us. Then we evaluate. In case if there is some abscess, we'll drain. That is not that common. It is very rare. Because the question was asked, I thought of explaining it about the infection in the retropharyngeal space.
Yeah, so that's obviously one cause of torticollis, but not very common. Thank you.
Not very common. Yes, exactly. Not very common. Yeah.
Sure. Mark, one more question, just an extension of the CT imaging. As physicians, the first thing when we come across when you have a wheeze which is uncontrolled or a wheeze which is suspicious or voice change, etc., most of us go for imaging. And the imaging of choice these days for airway problems or any parenchymal lung disease has always been a CT. So how about MRI? MRI imaging of the throat prior to your interventions, or you straight away go on for a video laryngoscopy?
See, I mean, earlier there used to be a lot of CT scan being done for all these intraluminal problems because of the availability. I mean, especially in our country, CT scan is very much available than bronchoscopy. So bronchoscopy is being done in specialized centers. So nowadays the number of centers where people start using bronchoscopies are becoming more and more. So this is even more better procedure because there is no radiation. Number one. Number two, the airway is a dynamic part. It's not just a static area where you need to pick up something, right? So when you suspect intraluminally, if you do scopy, you are also seeing the dynamics of the airway from the nasal cavity till the bronchus. You are not missing out any single part because the airway can, a problem at any point, if there is an obstruction, it can confuse you. So that's what we have been seeing. We have seen in all those cases. So it is better to do a proper airway endoscopy from nose to the bronchus instead of taking a CT scan MRI in one particular area. So that is the advantage of doing a bronchoscope. And bronchoscope, one problem was earlier, like you need to get something like Olympus bronchoscope or Stores bronchoscope. It's like 25 lakhs, 30 lakhs. No individual person or small hospitals can invest on that. Nowadays we are getting a chip on tip bronchoscopes, which is available like disposable scopes. You can easily purchase it, and anybody can start doing it. And the learning curve is also very less for these scopies. And once you start doing that, then you will be able to pick up a lot of things. So we are moving away from doing imaging for airway problems nowadays to the direct visualization by scopies.
Thank you, sir. There is a question by Dr. Neelagandan, sir. He wants to know about high frequency jet ventilation during foreign body removal.
Yeah, I mean, we use jet ventilation. One of the very few centers in the country to still use the jet ventilation, because many centers, especially abroad centers, are moving away from jet ventilations. They're moving on to the spontaneous breathing, spontaneous ventilation. But our center, it is being done for almost like more than 40 years. So the anesthetists are very comfortable using it. So we have been using jet ventilation for foreign body removal. One problem is, like, at least theoretically, if you are giving a jet inappropriate time or inappropriate pressure, then there is a possibility of barotrauma or pneumothorax. That is a very catastrophic situation you will land up if you are doing it without much experience. So in my center, yes, we are doing the jet ventilation. If you are going to other centers, people are moving away from jet ventilation. But high frequency jet ventilation nowadays, automatic metronic unit has come, so you can give automatic jet ventilation for other procedures, not only for foreign body removal, other procedures where you need space for surgery, and you can pass a small catheter to give ventilation and do the surgery. There are centers that they're using high frequency jet ventilation, and also we are using high frequency nasal airflow with with good oxygenation, and also doing a successive apnea technique without tubing for surgeries.
So Dr. Gokula Krishnan wants to know when to evaluate for snoring in children. Snoring.
Yeah, I mean, yeah, snoring is another big topic. That's why I didn't want to touch upon those areas. Snoring in children is abnormal. Any child who snores, we need to evaluate. And more so, there are two different kind of snoring. One is simple snoring. Another one is snoring with sleep apnea syndrome. So we need to know, is there any apneic episodes? So what I do is we ask the patient to take a video sleep recording of, now everybody has a cell phone, everybody can record, and ask them to record the child during sleep. And we see, is there any apneic episodes? Then we immediately evaluate the child. If needed, we evaluate for other areas of obstruction by polysomnography, or else we can, if you are sure that this is only because of the adenoidal hypertrophy which is causing apneic episodes and snoring, then we straight away go ahead with adenoidectomy, and the child will become all right. But you need to see whether the child is really having apneic episodes before going into do adenoidectomy. And adenoidal hypertrophy itself is not a disease. Adenoidal hypertrophy along with snoring and apneic episodes we take up for surgery.
Any new updates on recurrent respiratory papilloma, sir? Papilloma management?
Yeah, recurrent respiratory papilloma is, luckily, it's come down drastically. I don't have much experience of recurrent respiratory papillomatosis. Previous generation would have had very good experience because now the incidence has come down, maybe because of the vaccination. And a good thing is now the HPV vaccination is being done by Tamil Nadu government for all the girls of 14 years old, and probably that will completely eradicate the recurrent respiratory papillomatosis in future. And also the monoclonal antibodies now changed the total kind of management in the recurrent respiratory papillomatosis, and the interval between the episode and surgery has come down, and the majority of the children have become all right once the child grows to adolescence.
Thank you, sir. If there are any further questions or comments? I think there are no further questions or comments. So thank you, sir. Thank you so much for your beautiful, illustrative, and short on time speed presentation. And I think it was really a privilege to listen to you on this forum. Thank you for your time and as well as your expertise. Once the talk is over, I'll make a recording and I will put it up in our YouTube site and share the link to all of you. Thank you so much for being with us.
Thank you so much. Thanks for the invitation again, Dr. Venkatesh. It was wonderful talking to our friends. One of my classmates has commented. It's great to be on the forum where we can interact with our alumni. Thank you so much. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.